This presentation is about blood sugar control in the ICU. As an introduction, hyperglycemia is common in critically ill patients. Current literature shows conflicting results on the effects of more intensive glucose control versus conventional control in the critically ill patients. Hyperglycemia commonly ensues in ICU patients, even in patients who do not have pre-existing diabetes mellitus. The rationale behind the use of insulin therapy is that severe injury or infection alters carbohydrate metabolism, which results in insulin resistance. There are three types of hyperglycemic patients in the ICU. The one with the known history of diabetes, the one with existing but unrecognized diabetes, and the one with stress hyperglycemia. Now, why is blood sugar control so important? Hyperglycemia adversely affects outcomes. Hyperglycemia impacts the mortality, the morbidity, the rate of infections, and also ICU length of stay. This study, published in Circulation in 1999, showed that hyperglycemia was a close predictor of mortality following cabbage in diabetics. It showed that if the first post-op glucose was more than 200, the length of stay of the patient was twice as long, the vent duration was 3 times as long, and the mortality was 7 times as long. It also showed that if the blood sugar level is less than 1.4, the post-op mortality is about 1.4%. If the blood sugar post-op is more than 250, the post-op mortality after this cabbage is about 8.6%. Another study that was also published in 2004 showed that intensive insulin management in medical surgical ICU improved mortality. It showed that when the mean blood sugar was about 130 in those patients, there was a 29.3 reduction in mortality compared to the control group, where the mean blood sugar level was 152. The intensive insulin therapy in critically ill patient, or LEUVEN-CQ study, is one of the landmark studies for ICU blood sugar control. It's a randomized controlled trial where 1,548 patients were admitted to a surgical ICU receiving mechanical ventilation. The patients were assigned to receive either conventional therapy, which is IV insulin only if blood glucose was more than 215 milligrams per deciliter, and the target blood sugar level was between 180 and 200, with a mean daily blood sugar level of 153. And the second group was the intensive therapy, where IV insulin was given for blood sugar control more than 110, and target blood sugar levels of 80 to 110, and a mean daily blood sugar of 103 milligrams per deciliter. This study showed a decrease in mortality, bacteremia, duration of antibiotics, duration of mechanical ventilation, duration of dialysis, and duration of ICU stay in all patients that received the intensive blood sugar control therapy. The next study we're going to talk about is the NICE sugar study. It's one of the landmarks study, and most of the ICUs actually use that study to measure their blood sugar. First, what is NICE sugar? NICE goes for normal glycemia, intensive care evaluation, and sugar is survival using glucose algorithm regulation. It was published in 2009 in the New England Journal of Medicine. It's an open-label, randomized control trial, multinational. It included 6,104 critically ill patients. It compared an intensive insulin infusion versus conventional infusion. The intensive infusion tried to keep the blood glucose less than 110 and the conventional infusion less than 180. 90-day survival was the primary endpoint. As a description of the study, 3,054 patients were assigned to the intensive control group and 3,050 patients to the conventional control group. The mortality in the intensive control group was 27.5%, and in the conventional control group was 24.9%. Severe hypoglycemia, which is blood sugar less than 40, was recorded in 6.8% of the patients in the intensive control group versus 0.5% in the conventional control group. This graph here represents the blood glucose values according to the treatment group. As you can see, the blood glucose values is lower with a mean of 108 in the intensive glucose control group. This slide here represents the actual probability of survival in the both groups. As you can see, the probability of survival in the conventional glucose control group is higher than the one in the intensive glucose control group. This table here shows that the probability of operative admission, diabetes, severe sepsis, and death were all lower in the conventional group than in the actual intensive control group. So again, the nice sugar study showed decreased mortality in the conventional control group, less risk of hypoglycemia, good sugar control, and less risk of being on an insulin infusion. It showed no difference in the 30-day mortality in the ICU days, in the hospital days, in the days of mechanical ventilation, in the days of renal replacement therapy, and the rate of organ failures. Just to discuss this study a bit, the main positives are that it's a large multi-center study. It has a good statistical analysis. It uses a uniform insulin protocol between the sites. The primary outcome of this is unbiased, and it's a good representation of clinically ill patients. And another great advantage is that it enrolled more patients than any trials that preceded it. The limitations of this study: more patients in the intensive group receive corticosteroids, which affect the variable we were studying. 10% of the patients in the intensive therapy were discontinued prematurely. There was no significant difference in the primary outcome, which was death, and the study was not blinded to the treating personnel. The main reasons for the discrepancies between the studies are there are differences in the population of patients, differences in insulin treatment protocol, the glucose goal, the glucose concentrations that were achieved were different. The use of parenteral nutrition was different in those population of patients, and also the expertise and experience of nursing staff at a particular institution could also influence the outcome. Another critical but very frequently overlooked factor is the method used to measure glucose levels. If the glucose level was measured through arterial blood gas or through capillary blood with point-of-care meters, there are also variable differences between different glucometers. Future questions that could be asked are: what is the optimal target for the glucose therapy? 2. Does a particular subset of patients benefit from tight glucose control? 3. What about hypoglycemia? And 4. What are the strategies for future management of glucose in the ICU? Just a few points to conclude. The nice sugar trial adds to the accumulating data on the use of tight glucose control protocols in patients in the ICU. However, the study does not close the case on these protocols. Further large trials are necessary if the question of whether intensive insulin therapy improves the outcomes of selected ICU patients is to be unequivocally resolved. As the dose of insulin used in critically ill patients is determined exclusively by the blood sugar value, accurate measurement of glucose concentration is essential to achieve the desired target to avoid hypoglycemia. In multicenter trials, a particularly important issue is that glucose measurements among institutions are standardized to avoid variability among patients. Highly accurate measurements of glucose concentration will therefore be necessary in future research.